relevant there for, yeah, sorry, the notes aren't even relevant to this talk, sorry. So you can ignore all those if there's notes showing there. Thanks, Michelle.
Sorry, Greg. The slides haven't changed on the screen.
Which one are you?
We're still on the first one.
Oh, you on the first one? That one? They're not changing at all?
No.
Don't know what's going on, Michelle. Try again. That's no good.
If you wanted to, sorry, everybody, just give us 2 minutes. If you want to slide them into Teams, I could change them for you from my end.
Okay. Yeah, but no idea what's that. I haven't had that problem before.
No. Here we go. Lucky we're all health professionals, so we're very used to working around the issues, aren't we?
Yeah, sorry about that. I sent you that, Michelle. I don't
know.
If...
That's come. Let me just share my screen. What? Okay. I'm going to have to share it from Teams because I can't quite.
Okay.
Oh. Did that work?
I can see the slides.
Yep.
So that
there we go.
We're up to about here, I think. Yes, this was the funding by the Department of Health and they developed a working group to really redesign the process to improve medication safety within the ED department at the Royal as a 12-month project, and we were the evaluators with our PhD student. Next slide, please, Michelle. So the normal process typically looks something like this, where one of the ED doctors would obtain a medication history from the patient and utilise that in charting the medications that the patient would receive in ED, and then on admission, if they are admitted onto the ward of the hospital. At some point, this doesn't always occur, but particularly with shortages of staff these days, but a clinical pharmacist would undertake a review of the medication chart on the ward, and they would also determine what's called a best possible medication history, the BPMH. And they may, for instance, contact the patient's community pharmacy and GP. They might look at My Health Record or other sources to try and determine, and of course talk to the patient, to try and determine what the patient was taking prior to ED presentation, reconcile that, and ensure it sort of matches up with what was intended. Because often within ED, I guess the issue is the admitting doctor, the ED doctor, doesn't have time to go to all those sort of sources of information. And this is where errors can occur, where they compile a list which may not be the complete list or may have errors in it. So it's often later when on the ward, the clinical pharmacist determines that there's some discrepancies or errors which then need correcting. So that's the usual care process typically. Next slide, please, Michelle. So what the working group came up with was this model where the pharmacist within ED would promptly, again, talk to the patient, would go to those other sources of information and compile this best possible medication history for the individual. and use that then and have a conversation. If the patient was being admitted, have a conversation with the ED doctor and developed a shared treatment plan, if you like, and do the charting. So the pharmacist actually did the medication charting. It was signed off by the doctor to meet legislation, but it was written by the pharmacist, who then communicated that information on to the ward where the patient was being admitted to. Next slide, please, Michelle. It was a requirement of the working group, not surprisingly, that there was some credentialing of the pharmacists, although what they were doing wasn't really a great extension of what they were trained to do and were doing on the wards anyway. But there was a formal credentialing process for these pharmacists, which is just shown on that slide. Details probably aren't that critical. Thanks, Michelle. We also had the opportunity to look at another slightly tweaked model. The working group were keen to see if having the pharmacist there and determining the best possible medication history and just handing that to the doctor would also improve things. So this is this so-called early BPMH model, where the pharmacist really just did that. They determined the best possible medication history, but they didn't have the conversation with the doctor and they didn't chart the medications. They just effectively handed that list of medications to the doctor, who may or may not have used it then in their charting of the medications. Next slide, please, Michelle. So effectively what we had were free arms to this sort of pragmatic trial. We're observing practice, essentially. It's not a clinical trial, obviously. It's just observing practice, but there are free arms to it in the different colours. So the left-hand side is the new model that we were testing, as we said, where the ED pharmacist obtains a best possible medication history, documents it, has a discussion with one of the medical officers, and the pharmacist charted the medications using that plan, signed by the medical officer, and handed that information over at admission to the ward. So there was that model. There was the middle one, the tweaked one, where, as we said, the pharmacist just handed the best possible medication history list to the doctor, who charted the medications. And the final one is the usual care process that we mentioned, where the medical officer essentially does all of that. And yeah, no, and just to note on that one, sorry, Michelle, the last one, just to note, what we used in this evaluation was then the ward pharmacist as the sort of source of truth, if you like, or the gold standard, where the ward or clinical pharmacist later did their own reconciliation again from scratch on the ward, and we used their findings to determine the sort of outcomes of the three different arms of this project. Thanks, Michelle. So what we wanted to look at obviously was the prevalence and the severity of errors, or what are considered unintentional medication discrepancies. So discrepancies between what the patient was taking and probably should have been taking and what they were prescribed to be taking in the hospital, recognising that things could have been changed intentionally. I'll come back to that in a moment. It's the unintentional changes that we're obviously focused on, the errors. We had a number of secondary outcomes to look at. We wanted to look obviously at things like length of ED stay and length of hospital stay, readmissions, occurrence of adverse reactions, etc., time to receive critical medicines. We'll talk about that. We did do some qualitative work. I won't present that today, the staff satisfaction. Next slide, please, Michelle. So the errors we're talking about with the medications are of different type. They're often omitting a drug from the list. Could be putting the wrong drug, similar name drug, but wrong drug that the patient mentioned, different doses, etc., different routes. So these are all possibilities of error types. Thanks, Michelle. To help us, we had a panel of 3 experienced clinicians who looked at a random collection of these undocumented discrepancies. So firstly, they were asked to decide whether because one of the problems here, I've alluded to it briefly already, is where there are discrepancies between what the patient was taking at home and what is prescribed in the ED, could be intentional. There could be changes that are made by the ED doctors. The problem is they may not document the reasons, their logic or rationale for the change. It's not an error, obviously, if they've made an intentional change and it's based on a good clinical reason. That's not an error as such. So we needed our panel to investigate that when it wasn't documented, the reason wasn't documented why there was a discrepancy. So we relied on them to help us guide whether it was an intentional change, which wouldn't be an error, versus an unintentional change, which would be an error. They also used a published matrix to rate the severity and the likelihood of the error leading to harm. We'll come back to that. Thanks, Michelle. This, you may not be able to see it very well. It doesn't matter too much. It's just indicating on the right-hand side the level of detail. We gave the panel members quite a bit of detail, background information on the presentation, on the patient, the discrepancy or error. In this case, it was lacking an insulin preparation. We gave laboratory tests, and in this case, in fact, the omission was evident through the blood glucose increase that occurred at one point. But we gave them all that information, and that was important because, again, to perhaps determine whether the ED doctors had intentionally made a change but not documented the rationale. So that background information was important for our panel, past medical history and so on. So they were given that. What they did was on the left-hand side, basically, and I've sort of mentioned that to make a determination whether the discrepancy was probably intentional or not, and then looking at the severity and the likelihood, and that was guided by a matrix from the Society of Hospital Pharmacists, who have a risk matrix which looks at severity and likelihood and then grades the error based on that. We had, as I said, we had 3 panel members do that. We had several, it was like a sort of modified Delphi process. We had several rounds, and ultimately, when needed, we also had a 4th clinician come in and moderate if needed in the final step. Thanks, Michelle. So we tried to keep this evaluation very much independent from the process in the hospital and where we could blinded. So it was independent in regards to the clinical pharmacists on the ward when they were just doing their normal job, charting, determining their best possible medication history, etc. And we relied on that as the gold standard, as we said. We had our PhD student was the data collector who was independent, and then our panels was independent and also blinded as to which group, which arm the patient was in. Thanks, Michelle. So we did try to do it robustly. It's difficult, obviously, with a sort of pragmatic trial. It's not again, I say it's not a randomized clinical trial. This again, sorry, it's a little bit hard to read and blurry. It's showing the patient numbers. So ED presentations, we're Royal Hobart, that's the average typical figure there. They have about 65,000 presentations per annum now. There's a number of exclusions, obviously. We only want people who are admitted to hospital. And also the focus, and there are also exclusions because the focus was primarily on older individuals and on individuals taking multiple medications. Furthermore, there was an exclusion in that our focus originally, it did broaden a little bit later during this year trial, but early on it was medical, gen med general medical admissions that we focused on, not specialty admissions as such. So there were exclusions. The other exclusion, which is an important one, we'll come back to at the end, is the box in yellow. And that's often because we didn't have the ward pharmacist doing the best possible medication history. We didn't have our comparator. And you can see there, if you look at those numbers, roughly they were doing it about half, and it's probably less now, but during the phase of this project, the time of this project, they were seeing about half of patients on the gen med wards. That again reflects the sort of stretched limitations at that time, which have only worsened. So we didn't always have our comparator, so that meant some exclusions. So we ended up with the eligible patients as shown, and then we randomly selected a number of those from each arm. Thanks, Michelle. And this is just showing the patient characteristics. Not surprisingly, the point to make here is the ones that had the PPMC intervention by the ED pharmacist, and they had time restrictions as well, obviously work restrictions in the ED. It's not surprising, and they, as we expected, they sort of prioritised the older patients and the more complex patients in terms of Charleston comorbidities, and in terms of number of medications were a bit higher in that group. And that's not surprising. It is something to bear in mind when we look at the results, because they're actually probably tackling the more complex patients. So that's probably diluting the effect of the intervention to some extent. Next slide, please, Michelle. This is then showing the discrepancies and the errors across the three groups. So firstly, on the left-hand side is just the discrepancies as they came. That's without looking at that's without the panel looking at whether they were intentional discrepancies or not. The middle bit is after the panel has made a determination of whether it's an error. That is an unintentional discrepancy. So that's the middle part of the slide. And you can see there the message is, one of the messages is that in most cases in the control group, the usual care group, and in that early BPMH group where the pharmacist just gave the list to the doctor in ED, most of the discrepancies are actual errors. They seem to be unintentional. The height of those bars doesn't drop much between the left-hand side and the middle. The PPMC group, bit less so. It's probably about half were unintentional or errors. The other thing, of course, you can see from the slide is there's not much difference between the usual care. And there wasn't in fact a statistical difference between the usual care and the early BPMH group. And the key part is probably the right-hand side circled. Then these are the errors, focusing on the errors deemed to be high extreme risk or posing a high extreme risk to the patient. And you can see the percentages there, 1% in the PPMC group and about a quarter in the other two groups. So a massive difference between the groups, but not between the usual care and that group where the BPMH list was just provided to the ED doctor. Next slide, please, Michelle. An alternative way to look at that is errors per 100 medications rather than per patient. Per 100 medications, the numbers are there. Again, much lower numbers of errors in the PPMC group. Next slide, please, Michelle. Or converting that to number needed to treat, so number of patients who needed to be given a PPMC to prevent at least one additional error or to prevent at least one additional error of higher extreme risk. Probably again focusing on the higher extreme risk, you need to do about 4 PPMs or have about 4 patients undergo PPMC, which isn't that many, to prevent one additional significant error. Next slide, please, compared to usual care. Next slide, please. The types of errors, mainly omitted drugs, missed drugs, but also dosage issues, dosing frequencies, size, dosage issues, probably the second major issue. Next slide, please, Michelle. I'll just mention a couple of those. You might be interested. A couple of those cases as examples. So the first one, this was a lady who normally took pregabalin, 75 milligrams twice a day for neuropathic pain. If you don't know that drug, it's used essentially for neuropathic nerve pain. And she was inadvertently prescribed double that dose, and perhaps not surprisingly developed drowsiness, etc. That's a well-known expected side effect: dizziness, drowsiness, hypotension. So that's what happened to her, and that was subsequently ceased. Next slide, please, Michelle. This one was a patient where their diuretic therapy was missed from their usual meds. So a patient with significant edema. The admitting team, in ED, there was documentation that they were to continue the diuretics, but some, for whatever reason, they were inadvertently omitted from the drug chart. So that was another significant error. Next, please, Michelle. There were a few insulin ones, and this is patient missing insulin from the chart, and finally a patient taking a pixaban, a blood thinner, an anticoagulant for stroke prevention in chronic AF, missing from chart. So they're just to illustrate some of the sort of examples or errors that were occurring. Next slide, please, Michelle. So at this point, that part of the research tells us that the PPMC seems to be associated with reductions in significant medication errors compared to both other models, the usual care or just giving the best possible medication list to the ED doctor. As noted in the second point, that giving that list to the ED doctor didn't really change much. Whether that was because they weren't using the list, or whether the discussion wasn't occurring also with the pharmacist. So it highlights the criticality, I think, of having that collaborative discussion prior to the charting. Next slide, please, Michelle. Some of the other outcomes then, let's go on to those. One we wanted to look at was the use of potentially inappropriate medications, in that there was that discussion occurring between a pharmacist and the medical officer in ED, which may have led to changes in therapy in ED. So we wanted to see if, apart from reducing errors, whether there was actually better medication usage coming out of that discussion. Next slide, please, Michelle. So we did that. Given the patients were predominantly elderly, we used, you may not be familiar with this, the Beers criteria, which are an internationally recognised set of criteria coming out of the USA. They've been updated again now since that time. We have the 2024 Beers criteria, but at that point we had the 2019. They essentially list drugs that are best avoided in elderly patients where the risk is deemed greater for most patients relative to the clinical benefit. So we looked at patients, prescribed those. We looked at free time points. We looked at when they came into ED. So that is what they were taking at home prior to coming to hospital. At the point of ED departure and going onto the ward. So after that charting process in ED, and thirdly at hospital discharge. And we looked between the groups and within the groups for changes. Next slide, please, Michelle. So very briefly, the results are in this figure. The PPMC group in red, and you can see the percent of patients who were prescribed at least one potentially inappropriate medications, and you can see that's above about 50%. It did drop substantially within the PPMC group by the time of ED departure. So presumably following that discussion between the doctor and the pharmacist and the charting, coming up with that shared plan and the subsequent charting, there was a significant drop. But you can see there is some reversion, there's some increase back up again by the time of hospital discharge. The other two groups, not really substantial changes across the free time points. Next slide, please, Michelle. So it appeared also that the PPMC was beneficial and also improving medication usage, not just fixing possible errors, but improving the appropriateness of medication usage. Although there was the downside that some of that seemed to revert by the time of discharge. And that, I guess, highlights the importance of having that continued close collaboration on the wards after movement from the ED. Next slide, please, Michelle. Another aspect we wanted to look at was the timing of critical use of medicines. So some medications, it's really important to get those commenced or not to miss doses by an extended interval. Parkinson's drugs are just one example of that. So we wanted to look at whether the PPMC altered that process. Next slide, please, Michelle. And in fact, having the pharmacist there and doing the charting with the doctor did lead to substantially shorter times to receive the critical medicines. So that was highly significant. Also improvement in other things mentioned there, the clarity of the chart, etc., and in the VT, the venous thromboembolism risk assessment conducted in ED. That was, as you can see, 97% in the PPMC group. The in-hospital adverse reactions didn't change. We didn't really expect them to. One of the problems there is it relies on coding, administrative coding, which we know sort of under detects those issues. They're often not reported in the administrative coding. Next slide, please, Michelle. And economics, we're getting towards the end now if you're worried, but economics, we did do we tried to make it fairly robust, but I wouldn't say it was a extremely well-developed cost effectiveness trial, but let's have a look at what we did. Next slide, please. We're particularly interested in things like length of hospital stay, so time to a hospital discharge, essentially, whether that process in ED made changes to the stay, but we also looked at hospital mortality and readmissions, etc. Next slide, please, Michelle. Now, one of the issues we showed earlier on that the patient groups differed quite a bit. The pharmacist gave priority to those who were older, who had higher comorbidity load, etc. So we had to do propensity matching statistically, if you've heard of that or if you've done that yourselves, to match the groups as best we could. Next slide, please, Michelle. This is just showing the detail there. The left-hand side is just showing unmatched, which you sort of saw before. And this time we're just looking at two groups. We haven't bothered to look at the early BPMH group because we could see already not much happening with them. So it's just comparing usual care and with the PPMC model. Left-hand side, as we said, significant differences when they're unmatched. Right-hand side is just showing that our matching worked. The p-values there are all very high. There's no significant differences after we've matched them for all those variables on the left-hand side. Thanks, Michelle. So we had about 309 in each group after matching. There were, however, after that matching, there are still differences in the diagnostic, in the reasons for admission and the DRGs, the diagnostic codes. The right-hand side, I think, as an example, is respiratory infections. There's a bit of a difference there in the chart, in the bars. So what we use, which is usual practice, we use what is called the relative stay index. Next slide, please, Michelle. So the relative stay index does take account of different patient comorbidities, complexities, etc. So it tells us what the expected stay is for a patient, given their complexities, given their the principal diagnosis, etc. So the key finding was the relative stay index was reduced by about 15% with the PPMC, as you can see there. There weren't significant changes in readmission or revisits. Next slide, please, Michelle. The economics, we used DRGs, we use the Independent Health and Aged Care Pricing Authority, costs of admissions, etc., based on DRGs and translated through the relative stay index. So all that data, you can work that out. We had costs for the time of the pharmacist, the medical officer, the nurses, the extra time in discussions, etc. Next slide, please. So we could do some fairly rudimentary costings. And it was determined that, as shown there, the key finding was perhaps a saving of about $1,200 on each admission, given the 15% reduction in relative stay index per patient in that group. So quite significant savings with the PPMC model. Next slide, please, Michelle. So as I said, no significant reductions though in some of the clinical outcomes, like in hospital mortality, 30-day readmissions. There was, and this is again the problem with this pragmatic trial, not only did with the PPMC group, were they more complex, we had an additional factor in that, and I've slightly touched on already, where the ward pharmacists, the clinical pharmacists, doing their own reconciliation. That was better during this time period than prior to the time period, and certainly since that time period of this project. So normally only about a third or perhaps even less now would actually have that reconciliation, have that BPMH done on the wards. And so that probably helped the usual care group in that that may have averted some of the problems in the usual care group and lessened the influence of our trial to some extent. Next slide, please, Michelle. That's I've sort of said that we had that at the bottom there, the ward pharmacist doing that. And as I said, that they probably were doing that more often in the usual care arm than they were normally. Next slide, please. So towards the end now, we can go to the next one, please, Michelle. Some strengths and limitations. I've sort of touched on some of the limitations. It's certainly not a prospective randomised trial. We had to do propensity matching, etc. It's a single site, obviously. We did do some timing estimates, time and motion estimates, but they're subject to sort of variation, etc. So there are also some strengths related to that. We did the propensity scored matching, which did match up the groups pretty well. We had that panel, fairly robust process with the panel, etc., judging the discrepancies and judging their severity and so on in a blinded fashion. Next slide, please, Michelle. So key message, the model did appear to be beneficial, associated with reduced errors, reduced hospital admission costs, but giving the BPMH list just to the ED doctor didn't seem to be of any particular use. So it highlighted the importance of having that clinical discussion between the pharmacist and the doctor and that co-charting process. Next slide. Okay, so I've probably touched on that, the advantages, but probably the key advantage is that collaboration, that discussion that did occur in ED to come up with the shared plan and the charting of that. Next slide, please. This sort of model is being rolled out across Australia, partly based on our results. The problem we have, which some of you may be aware of course, is staffing these days. Even here at the Royal Hobart now, it's become a significant problem with performing this process. Just the relative lack of pharmacists as one member of the allied health team. Just the lack of allied health and other staff has made it difficult to sort of roll out this model nationally. So that's it, Michelle. Thank you. Sorry again about the technical issues. Don't know what's happened there. But
I'm going to stop the share. Thank you very much, Greg. There is a Q&A box. If anyone wants to ask any questions while you're typing, I was just thinking, as you were talking about this and you're talking about the age group, I was thinking I've just recently taken my mother-in-law to a Sydney ED, and the difficulty on obtaining the medication history of a patient who's 87 years old, probably with a little bit of dementia there, it's almost impossible to get that accurate.
Yes, and
without
that's
the
why,
resources.
That's right, and the ED doctors, of course, often don't have time to go to those other resources. So that's really the role of that pharmacist to go to those resources. Yes, absolutely.
I remember them saying, "Oh, do you know anything else? You know, any other medication she takes at home?" And I was looking in her kitchen before the ambulance took her away, and I found this jar, empty Vegemite jar, of different coloured medications, different sizes, and I went, well, there was a whole pot there, and I have no idea where they came from, what they are, if they're out of her Webster pack or if they're vitamins that she's using. So I can only imagine. So with Royal Hobart, have they implemented those changes as best they can with staffing limitations?
Yeah, they're struggling, Michelle, to be honest. They're struggling. It's not as active as it was, in fact, because of the staffing issues at the minute. But hopefully it'll ramp up again. No, so that's a little bit unfortunate. They have the funding, not the personnel.
Yeah, because I mean, you can see the answer's quite clear, isn't it?
Yes, the Department of Health did agree to continue the funding.
Yeah.
But just it's been difficult with not enough people applying and being appointed.
Well, it doesn't look like anyone's had any questions, but I have to say it was a really fantastic presentation, Craig. Very interesting. And I think probably for us online, or us healthcare professionals, very close to our hearts, especially, you know, the risk it has for patients and the number of medication errors that happen each year, and the cost not only to the healthcare system, but to the patient themselves. Everybody, not a question, but Donna said Queensland Health have employed more pharmacists. So that is good to hear. And Kelly said, thank you, a very interesting presentation. And for anyone who's interested, it has been recorded. So that link will be sent in the email that we follow up with.
Good. Sorry again about the technical.
That's quite all right.
Very amateurish on my part. I don't know what's happened there, but anyway.
Blame me and my Zoom setup.
No, it's all right.
All right, everyone. Thank you very much, and have a wonderful evening.
Thank you. Bye-bye.